Vestibular migraine makes people dizzy, nauseous, and scared, but could a single preventive drug cut those attacks in half? Here is the paper itself. Vestibular migraine is a migraine variant that adds spinning sensations to the usual headache, dramatically lowering quality of life. Before this work, doctors relied on old migraine drugs, while the brand-new CGRP antibodies were exciting but untested for vestibular migraine. Vasireddy and colleagues saw the evidence gap and set out to compare every preventive option using a network meta-analysis. The authors pooled 5 RCTs that together evaluated propranolol, valproic acid, venlafaxine, galcanezumab, flunarizine, and a probiotic, LCS, against control. Each trial counted how many vertigo spells patients had each month, asked them to fill the DHI questionnaire, and noted who stopped the drug early. The biggest drop came from propranolol, about 7 fewer attacks each month compared with control. All 6 treatments significantly reduced attacks. Propranolol showed the largest mean reduction, followed closely by valproic acid and venlafaxine. The newer CGRP antibody galcanezumab also performed well, with a moderate certainty evidence base. The authors evaluated each trial for bias. Only the galcanezumab study was low risk, while several older trials had some concerns, especially around blinding and missing data. Beyond attack count, the CGRP antibody gave the biggest boost to patients' perceived dizziness handicap, suggesting a broader benefit. Safety mattered. Galcanezumab stood out with no patients stopping early, while older drugs carried higher dropout rates due to side effects. In practice, doctors can reassure patients that any of these options will likely help, but they should weigh propranolol's indirect data against galcanezumab's solid trial results. The authors note that the network's shape meant they could not test for inconsistency. Many effect estimates rely on indirect links, and the trials only followed patients for up to 6 months. Future work should directly compare the top-ranked drugs, follow patients longer, and test whole drug classes rather than single agents. 3 simple rules. Use propranolol first, switch to galcanezumab for safety and evidence, and keep the others as backup options. Before prescribing, verify cardiovascular status for beta blockers, talk about the expense of monoclonal antibodies, and set up regular follow-up to track dizziness and quality of life. Thank you to the study team Vasireddy, Biswas, and colleagues, and to BMC Neurology for publishing this important synthesis.